So let's hear Professor Namrata Sharma about role of moxifloxacin perioperative sterilization.
So thank you, sir. I would be talking to you about role of intracameral moxifloxacin in prevention of post-cataract surgery endophthalmitis, and there are no financial or proprietary interests. And although post-cataract surgery endophthalmitis is decreasing over the last decade, but it is still the most ominous complication. As far as prophylaxis is concerned, we give preoperatively topical antibiotics. Povidone iodine and intracameral antibiotics have been advocated intraoperatively, and postoperatively one can give topical antibiotics. Globally, coagulase negative staph is the most commonest cause of endophthalmitis along with staph, but in India I think gram negative and fungal infections are also quite common. If you look at the ASCRS endophthalmitis prophylaxis survey, the respondents who would use the formulation is as shown, and in 2021, 66% responded said that they actually use it, vis-a-vis 2014, where 84% said that if there was one formulation approved, they will use it. This is the survey of 2021 ASCRS endophthalmitis prophylaxis survey. And in this, vancomycin was being used by 6% of the respondents. And reasons cited for those not using intracameral antibiotics was compounding problem, unconvinced of the need. And also, they said that there would be increased adoption of intracameral prophylaxis to the tune of 93% if there was a drug which was available. So if you look at the drugs between cefuroxime, moxifloxacin, vancomycin and cefazolin, moxifloxacin is now available, which can be given intracamerally, and other drugs have been tried over the last few years. The advantage being that the preparations are available commercially, wide spectrum of action is there, and has concentration dependent killing. This was the ASCRS study of prophylaxis of post-op endophthalmitis after cataract surgery, randomized controlled study, 16,000 plus patients, where rate of endophthalmitis reduced from 0.3 to 0.06%. That means there was 5 times reduction. Concerns with cefuroxime are emergence of resistant gram-negative isolates, higher visual loss in cefuroxime injected patients, and it has to be compounded in pharmacy. Vancomycin, on the other hand, was also used earlier, but there was a concern of hemorrhagic occlusive retinal vasculitis, and this was reported in this study, and so its use also became increasingly less. Intracameral moxifloxacin is available as preservative-free preparation, 500 micrograms per 0.1 ml. And this was a retrospective study from Arvind Eye Group in more than 1 lakh patients, where there was 4-fold decrease in the patients undergoing manual SICS. This was analysis on 6 lakh patients, where significant rate in endophthalmitis occurred from 0.07 to 0.02%, which was 3.5 times. And in PCR, the rate was increased by 7 times when intracameral moxifloxacin was not used, and it decreased to 0.21% where in PCR cases. Now this is the study from Japan, 19 clinics, and this study I'm quoting because it is outside of India, where again this showed that there was 3 times decrease of endophthalmitis with no TAS reported. Now, as far as the safety is concerned, you have to look at the endothelial cell loss and the pachymetry. And in 65 eyes, there was no significant difference which was noted. And this was a randomized control trial, 57 eyes. Again, no adverse event in terms of visual acuity, IOP, rise, endothelial cell loss, pachymetry, or AC reaction. Now, this was the first survey which we did in 2017, 4,292 AIOS members who responded, which is a fairly good response, 30.2%. And when we compared it with the ASCRS survey, we found that there was similarity in decision for pre and post-op antibiotics, but dissimilarity in the choice of intracameral antibiotic and decision for subconj. So from our continent, people were still giving subconj, and we see the difference between the two surveys in intracameral antibiotics. We find that cefuroxime was given more by the ASCRS survey and moxifloxacin more by our survey. Again, 17 study, more than 9 lakh eyes favored the use of intracameral antibiotics. And this is the only, in fact, randomized control trial which is done prior to our study and which has 3,000 eyes. And although it did say that there is the incidence of endophthalmitis was 0.05% in moxiflox group vis-a-vis 0.38% in the control group, the numbers are not as high and the power of the study was not that great. This was the second survey that we did from the AIOS, and again we concluded that intracameral antibiotic prophylaxis for cataract surgery significantly increased in India from 40% in 2017 to 58% in 2022. And we actually did this randomized control trial in 60,000 patients, and this was done because in ESCRS actually planned to do it, but because of lack of funds, they could not do it, and then in between the COVID came. So we started this study prior to COVID, had to suspend it during the COVID, and then further continued this study. As far as the aim of the study was concerned, it was in a randomized study to see whether intracameral moxifloxacin 500 microgram per 0.1 ml helps. And the sample size was collected, and each group recruited 30,000 patients. So we included 3 tertiary eye care centers: RP Center for Ophthalmic Sciences, AIIMS, New Delhi; Sadhguru Netra Chikitsalaya, Chitrakoot; and Tirupati Eye Center, Noida. And this study was in fact conducted from 2018 to 2024. 2 years hiatus was taken because of the fact that COVID was there. We included all cases undergoing phaco and IOL, age more than 40 years. And patients underwent phaco with IOL implantation. So topical moxifloxacin was given preoperatively. Povidone iodine was used. Group 1 had intracameral moxifloxacin, whereas in group 2, only phaco emulsification was done. And the parameters which are noted here were actually evaluated both pre and intraoperatively. And of course, post-op, again, moxiflox, steroids, and tropicamide continued. Whenever there was a case of endophthalmitis, all the protocol as per the endophthalmitis in any group, if it occurred, were followed. Now, if you look at the baseline parameters in terms of age, gender, best corrected visual acuity, IOP, endothelial cell density, central corneal thickness, it was comparable at baseline. And so were the incision size, type, location, IOL optic size, haptic position, type, wound closure, and also the posterior capsular rupture incidence. 6 eyes in cases where intracameral moxifloxacin was given, vis-a-vis 16 eyes where it was not given, developed endophthalmitis, and this was statistically significant. So the odds of developing endophthalmitis if you don't give intracameral moxifloxacin as per this study was 2.5 times as compared to the control group. Again, this is to look at the age, gender, history of PCR, mean latent period, and presence of hypopyon and systemic illness as far as the endophthalmitis is concerned. And this is the data which is shown. In terms of microbiology, 2 in the intracameral group and 6 without the intracameral group were positive and for cultures. And as far as the resistance pattern is concerned, ciprofloxacin, gefloxacin, and moxifloxacin, 5, 3, and 2 cases were resistant to it. In terms of the visual acuity, IOP, mean endothelial cell density, central corneal thickness, central macular thickness, which was also evaluated in these patients, none of the values were found to be significant. AIOCMTC4 in between we found did give an advisory on the concentration and on the amount of the moxifloxacin that one should inject, because if you do not do it in the correct dosage and the correct concentration, then there can be TAS present. As per our study, we did not find any TAS in our study. So again, the 2 different concentrations which are available are 0.5% and 0.1%. So to conclude, intracameral moxifloxacin is safe and efficacious in prophylaxis of endophthalmitis after cataract surgery. An additional use of topical antibiotics needs to be validated after cataract surgery. But having said this, we all are giving pre-op antibiotics, post-op antibiotics, and of course, if you give intracameral moxifloxacin, that increases the safety as far as the infection is concerned. Thank you very much for your kind attention.
Thank you, Dr. Namrata, for a wonderful presentation and quoting all these studies. So I would like to know from the audience, how many of you are not using intracameral antibiotic? So quite a few of them. So Dr. Ragini Parekh, what is your reason for not using intracameral antibiotic? Mike, please.
So initially we were very scared to use anything intracamerally because in between there were problems with drugs which were directly used intracamerally and caused TAS and all that. So we do use the drop post-operatively, but we are not using it intracamerally, sir. And yes, sir.
Does anybody else would like to comment? Why they are not using intracameral antibiotic?
So we have not used it intracamerally in thousands and thousands of surgeries. But what I feel is that to prevent end-off, there are not only intracameral drugs, but lots of factors which are involved, which need to be controlled, managed. I mean, surgery, cataract surgery takes 5 minutes. But before surgery, during surgery, after surgery, starting from the patient, I can talk on quality control for hours and hours because we used to do 2,000 surgeries at a time. So I do believe that it is not only the intracameral drug, but there are so many other factors which also help. But with newer drugs which are safer intracamerally, I think that would be an added safety.
Dr. Namrata, you would like to comment? A lot of people are not using intracameral antibiotic.
No, I think it is up to one's own discretion whether you want to use it or you don't want to use it. Some people are not using it, some are using it, some are using it only if they have a PCR. But this was just to validate a point whether the use decreases endophthalmitis or not. And this paper got accepted last week in Journal of Cataract and Refractive Surgery and was also awarded the best paper of the session in AIOCMTC4. But having said this, I think maybe moxifloxacin today, but maybe the drug might change tomorrow, because if resistance occurs to moxifloxacin, then what next?
Yeah, I think I would like to comment over here, ma'am. I totally agree with you. We are using, at Center for Sight, we have been using intracameral moxifloxacin for the last, I think, 7 years now. And there's hardly any case of end-off. It has drastically reduced the incidence of end-off. And if you use preservative-free moxifloxacin, actually it doesn't cause any problem. Though there are isolated case reports of BAIT or the transillumination defects of iris. Have you seen any such case?
No, we did not come across any such
request Dr. Rajesh
effects.
to
But,
give his
but one thing is definitely there, that you should use it in the right concentration and you should use the right volume. And now, because you don't have to compound it, earlier you had to compound all the other intracameral antibiotics, you can use straight from the vial. So the chances of it going wrong are less.
Actually, it's a fact that a lot of us, we are not using intracameral moxifloxacin, and I have also not used it for many years and never had an endophthalmitis. So as Dr. Ragini was telling, there are many other factors that govern, that that are related to the occurrence of endophthalmitis, which we have to take care. Having said that, over the last few years, I've started using intracameral moxifloxacin because now it's an era of litigation wherein people, even the opposite lawyer can quote articles related to this wherein it has shown definite benefit of intracameral moxifloxacin. Now, once again, having said that, people have shown a couple of reports of TAS. Now, there's a very interesting study done which has been published in, I think, Ophthalmology or JCRS. It was done by William Myers along with David Chang. and they actually gave the correct concentration and dosage of moxifloxacin. So what we have is 0.5% of moxifloxacin that should only be injected, only 0.1 ml of 0.5% of moxifloxacin should be injected. And if we are using 0.1% moxifloxacin, which is not available here, but it is available in US, there the dose was 0.5 ml. Now, any amount which is more than 0.1 ml of 0.5% moxifloxacin, if you inject intracamerally, the risk of TAS significantly increases. So, we have to be careful in the usage of drug when we are using it intracamerally in order to prevent TAS. And as I said, now this is an era of litigation wherein all these documents, all these papers, publications are available for all the lawyers. So just to play safe, and also there is some evidence that
I think there is evidence also now.
There's
so
that's
safe
true.
is one thing, but if
So
There is enough evidence that
I think
intracameral moxie
Rajesh has really very nicely summarized, and Ragini Parekh has definitely raised a very valid point. And I primarily, personally feel the cause of endophthalmitis is the poor wound construction. And I find at least 50% of the people who do phaco, they don't make wound properly. They don't make a limbal incision. They are clear corneal and just 1.25 millimeter of this and leaving a leaking wound. Because when you are operating, at that time you are washed with the betadine, so much of fluid is going. At that time there is hardly any chance of bacteria going in. It is the post-operatively, the ingress of the fluid, when the cadaver flora is again there, when it is sucked in, it causes endophthalmitis. So I had no case of infection for many years, but at the same time, as Rajesh has very rightly pointed, this is the time of a medical legal time, and injecting moxifloxacin, I have found no side effect whatsoever till date. Only thing, when you are injecting, do not keep the IOP very high. There should be enough of, if the IOP is very high, the fluid will come back. So it will reduce the concentration. So keep the IOP slightly on the lower side and inject more onto the deeper side, other side of the incision, so that the minimal leakage of the fluid and there should be adequate concentration inside the IOP. There is no need to try to put into the capsular bag, but that's very, very difficult and chamber tends to collapse. Just putting into the anterior chamber is good enough, and moxifloxacin as of now looks the safest option for us.
not be more than 0.1
Yeah,
ml
0.1
because
ml,
studies
that's
have
the
shown.
standard.
Yeah.
So with this, I think